Hello. Good morning, everyone. Oh, good morning. We will sit in a kind of a briefing capacity. The county council is literally in two places at one time, which we often have to do at the end of session when we're trying to when we have limited time and we are trying to do everything at the same time. So, good morning. This is the County Council sitting as the Prince George's County Board of Health in a briefing capacity. Present, we have the Vice Chair, myself, and Councilman Blagay, who leads our Board of Health. And today, we will be discussing maternal and infant health assessment. And with that, I will turn it over to Councilmember Blagay.
Thank you so much, Chair. I do appreciate you all coming out today. I know this is a busy day, but I want to note that maternal health has been one of the biggest issues that we've had in the county and the state. We have a high infant mortality rate for being a county with as much wealth as we have. So it's time for us to focus on that. Many of the babies that were born to our residents are not even born in the county, and we just need to make sure we do proper prenatal care. So I want to turn it over to our vice chair, who has been the leader on this issue, making sure that we focus on maternal health, and I wanted to give her this opportunity to lead this meeting today, as this presentation is really important to the community.
Thank you so much, Councilmember Blagay. Just want to echo those sentiments again. As many know, I became a mother 2 years ago now, and I went through that process as serving as a council member, and so many things were brought to light. Things that you hear about, the statistics, but you experience them firsthand when you're living them. Like the council member mentioned, even though I live in the county, I serve the county, I have health insurance through the county government, I was not able to give birth here in Prince George's County. It's one of the reasons why we passed legislation around provider care for insurance that the county government has, and mandating that they have certain services that are available within the county that we live in. We worked on legislation around access to parental leave. It's that day and age, I think, where we're starting to see women in different positions. And so, as we know, we didn't have a policy for elected officials. It made me also look at the policy for employees. When I actually started working for Councilmember Denoga, when I was his policy director, I was surprised at that time to learn county employees only had 5 days off for parental leave. I mean, that to me is laughable, right? In a modern day era in the U.S., and if we're trying to be a model of a government. So I'm so excited that he had championed for more days. Then when I got elected, I championed for more days. Then we worked on the Black Maternal Health Fund. Then we finally got it funded. Then we fought for this evaluation that we're going to be seeing here today. Because for me, what's really important is that it's one thing to know we have an issue and to talk about the issue over and over again. But the reality is to take a step back and assess what we're doing and make a strategic plan on what we can do moving forward. I think that in Prince George's County, we have the opportunity to be the staple, to be the example for the entire country to follow, especially when we have federal leadership now that doesn't want to have the conversation around Black maternal health. We went for this being a topic that was talked about under the former Vice President Kamala Harris to now a topic that will be stripped away from federal conversations around health and policy. And so, if not Prince George's County, then where else do we have an opportunity to forge better numbers, better statistics, better programs, better services around Black maternal health. So just thank my colleagues for going on this journey with me, for being completely supportive of making this a top priority. I look forward to the presentation to understand better what we're doing, what more we can do, and where we should be targeting our resources and building our provider care. So thank you for allowing me opening remarks, and I'll yield back to you, Councilmember Begay.
Thank you. I'd like to turn it over to Anya to introduce our speakers for today.
Thank you so very much. Good morning, Vice Chair Oriata and Councilwoman Begay. Today we have Dr. Dayan Yan, Director of Family Health Services Division, as well as Dr. Sheila Karat McRae, a Program Evaluator, also from Family Health Services Division from Prince George's County's Health Department. And I would like to turn over to our speakers. Thank you for their presentation.
Thank you, Anya. Thank you, Councilwoman Begay and Vice Chair Oriata for giving us the opportunity to present this morning. The slides are not up. There we are. Today we're going to provide an update on the maternal and infant landscape as we see it today. The last time we presented before the board was in 2022, and some things have changed since then, and we wanted to discuss our way forward and to show where we are aligning our work with CR 0992025. And why we're here today, maternal and infant health remains an urgent county priority because the disparities continue to exist within this county. And we know that education and finances alone do not protect Black women and babies from the poor outcomes that we continue to see. We're going to talk about the things that we lead within the health department, where we stand with our partners throughout the county, and then how we measure our impact along with presenting our priorities for FY26 and FY27. Dr. Sheila Karat McRae will take the next few minutes to review our epidemiology landscape.
Hi, good morning. I'll start out by just talking about some of the overall data in Prince George's County as it relates to maternal and child health, as well as some data that relates to the programs that the Prince George's County Health Department does put forward for maternal and child health. So on this first slide, you'll see that pregnancy-related deaths over the course of 5 years from 2016 through 2020, and pregnancy-related deaths are deaths that are related to any sort of pregnancy complication. And Prince George's County had the third highest number in the state, with 11 pregnancy-related deaths over the course of that 5 years, behind Baltimore City and County. Next is pregnancy-associated deaths. So these are deaths that people who are pregnant, regardless of their cause of death, they have passed away. So pregnancy-related death also, Prince George's County was third in the state, for the highest number of pregnancy-associated deaths, which, like I said, is regardless of whether or not it was a pregnancy complication. Moving on to some of our programs just at the Prince George's County Health Department. At our Reproductive Health and Resource Center, or RHRC, you'll hear us speak about this during the presentation. We have a number of family planning appointments, which on average, about over the past 3 years, and all of this data coming up will be over the past 3 years, FY23, 24, and 25. On average, about 2,000 family planning appointments that come to the health department through RHRC. The number of new pregnant females that are identified through these family planning appointments and are referred to community partners last year did raise a little to 72 and has fluctuated over the course of the past 3 years. The number of women that are using long-acting reversible contraceptives, these are things like IUDs, has reduced a bit from 133 in FY23 and is at 53 during FY25. Now, our number of overall client contacts at RHRC has increased over the course of the past 3 years, and this is inclusive of family planning appointments, any STI testing, and things of that nature. Next is our Healthy Beginnings program. In the next two slides, we'll talk about our Healthy Beginnings program at the health department. The number of referrals for Healthy Beginnings case management for children from birth through age 1 has ranged to around 600, 650 for the past 3 years. And then we have the number of virtual visits for new referrals for the Healthy Beginnings program from birth through age 1, which has ranged from about 200 to about 150 over the course of the past 3 years. Next would be the number of referrals for follow-up for our Healthy Beginnings program, which was about 582 last year, down from about 700 the previous 2 years before that. And then the number of unduplicated mothers that receive Healthy Beginnings case management services in total, which is inclusive of mothers who have already had their babies and those who are pregnant as well. Has ranged around the 1,500 mark for the past 3 years. The final data slide also speaks about our Healthy Beginnings program. So we do track the number of teens that are below the age of 18 that receive Healthy Beginnings case management services. And this has been around 150 or so last year. And it has ranged from about 190 through 150 over the past 3 years. And then the number of babies and children referred to other county sources for one reason or another was about 800 last year. And that number did go up, the number of mothers that were referred out for a variety of different services. And then the number of mothers who were referred to addictions and mental health services range from we had about 17 last year, and that was down from about 31 and in the 30s the previous 2 years. But then our overall number of client contacts, and again, this is anyone that is referred to the Healthy Beginnings program who's doing case management while they're pregnant, after they have a baby, has ranged around 1,500 over the past 3 years.
Thank you, Dr. Corette McCray. So this is data, but behind every piece of data, there's a person and a story. So I just wanted to share a quick story. When we implemented our postpartum hypertension program in conjunction with Capital Regional Health, as well as HRSA, we started doing more home visits with mothers. And one of our first visits, we had a young lady that presented with symptoms of preeclampsia. Our nurses showed up at the door with blood pressure and some reassurance to her that she wasn't alone, connecting her back to care immediately, which helped to divert a situation that would have not ended well for her because she was severely preeclamptic. And she was able to arrange for someone to stay with her baby while she went to the hospital, and the nurse actually escorted her to the hospital. This is what we do at the health department. The nurses will go above and overboard to make sure people get what they need. And we know that disparities continue to exist in this county, particularly around Black and brown women. Progress is measured, but our inequities persist. We still have Black women dying 3 times at a higher rate than their white counterparts, which made us commit to the Black maternal health. And thanks to this council, we received the additional money to put forward in FY26 so that we could develop a program around Black maternal health. And when we look at the drivers of the disparities that we continue to have, we look at it at the system level, the provider level, and at the patient level. And at the system level, we find that there continue to be coverage gaps and fragmented care within this county. Providers continue to exhibit implicit bias and microaggression toward patients. And then at the patient level, there are access barriers and postpartum discontinuity. Addressing each level systemically through structural reform, respectful care training, and wraparound support services is the way that we have chosen to change this county and align with CR 099-2025. And just a brief overview of the maternal and child health programmatic portfolio within the health department. Dr. Corette McCray mentioned our Healthy Beginnings program, but we also offer dental services to pregnant women. We have the Vaccine for Children's program as well as for adults. We have TB surveillance and control, and folks are wondering why TB is on here because pregnant women still get TB, so we take care of them as well. Then we have STI and HIV surveillance because we're looking at things that cause congenital problems. We know across the country congenital syphilis is a problem. Last year, 300 babies across the country died from a preventable congenital syphilis incident. And we still have that problem within this county. No babies have died recently, but we want to continue that surveillance to avoid it. And then we have HIV surveillance. We went over 25 years without having one perinatal transmission, and we had one recently. And we are still working to avoid that happening again because it's completely preventable. And our Reproductive Health Resource Center provides women with choices and options to provide them with tools so that they can plan pregnancies. We know that unplanned and unwanted pregnancies have worse health outcomes. And then we have our WIC program, which unfortunately is caught up in that federal nonsense that's going on. But the state stepped in to ensure that regardless of what goes on at the federal level, that we continue to fund WIC fully. So we're okay through mid-December. And then we have the Black Maternal Health Program that we are implementing this year, where we're able to bring on board a doula within our own program and to work with our community partners as well. We also have our Fetal Infant Mortality Review Program and Child Fatality Review Program, where we are responsible for looking at every infant death in this county to look at causes and to make recommendations back to the state. And then the Child Fatality Review Program is a multi-agency legislative requirement that we review the deaths of all pediatric cases outside of FEMA within the county and to make suggestions back to the state as well. We also have our Administrative Care Coordination Unit, which provides maternal and child health linkages to care that are folks that are assigned to medical assistants. And they work directly with my nurses to make those things happen. And then Health and Wellness has the chronic disease management through Prevention Link for diabetes management and hypertension, and MCHIP, which is the Maryland Children Health Insurance Program, where eligible families sign up for care. When we came before this body in 2022, we made a couple commitments and we followed through on them, and I wanted to just update you on that. We work with the state to ensure that the doula pilot program for Medicaid reimbursement was implemented, and currently there are 9 providers of doula services and training that are approved by the state of Maryland under medical assistance to get reimbursement for doula services. And then we have been working with the GW University, where I also teach at, to look at how we dig into Black maternal health within this county. Prior to us being funded for the Black maternal health, I had worked with GW on a similar project for the District of Columbia, and we're going to mimic the same thing under Black maternal health in this county. Now, I'm going to talk about Jasmine's story because, again, there are people behind the numbers. Jasmine was a 28-year-old Black married female who was thrilled to be pregnant with her first child. She attended all her prenatal appointments, followed all medical advice, and trusted her care team. But early in her second trimester, she began reporting swelling and headaches. Her doctor dismissed her concerns. He told her it was a normal pregnancy thing. You're probably not drinking enough water. No labs were ordered, no follow-up blood pressure checks, no home visits. Jasmine continued to report her symptoms. Her hands swelled more, her face swelled more. Her blood pressure started creeping up. She even started seeing spots before her eyes. These are classic symptoms of preeclampsia. She went to the hospital. The nurse said these exact words: "You people always worry too much. Every little ache becomes a crisis." That single sentence, a microaggression, communicated disbelief and disrespect. Black women feel that every day. It reinforced the false stereotype that black women are overly anxious and exaggerate symptoms. As a result, Jasmine hesitated to continue to raise her concerns. Yet a few weeks later, she called the office about worsening headaches. The reception asked curtly for her insurance information before even asking for additional symptoms. She asked her, "Do you even have health insurance before we send you to the hospital?" This was another microaggression. It seems small to a lot of people, but it is very damaging. It's rooted in bias. It eroded Jasmine's trust in her providers and in her healthcare team, and it continued to make her more reluctant to reach out to the clinic. By her 8th month, Jasmine's blood pressure quietly escalated to dangerous levels. One evening, she developed severe headaches enough that her husband rushed her to the emergency room, where she was immediately taken to labor and delivery for an emergency C-section. Even though this was a near miss, Jasmine could have died, and so could her baby, and they both survived. Every missed opportunity along her care pathway reflected implicit bias at work. And we know implicit bias is unconscious stereotypes, but there was some bias in this as well, where people are conscious of their behavior. Implicit bias occurs when there's an automatic assumption about some perception or some behavior, but you don't consciously realize that you're doing that. It affects how pain, risk assumptions, and credibility is perceived. And then when we look at microaggression, which are beliefs about everyday things that people comment on that are very subtle, and they don't really realize the impact of their behavior on everybody that is receiving it. While individually small, these cumulative impacts are profound. They discourage communication, they delay care, and they compromise the safety of care. In Jasmine's case, implicit bias and the repeated microaggression delayed recognition of life-threatening conditions that she could have died from. Our work in Prince George's County directly addresses these failures. We are looking at continuing bias and respectful care training across the county within the health department. We have worked with the state on standardized protocols for symptom escalation and documentation, and then we implemented the postpartum hypertensive collaborative to ensure that women have a 3-day postpartum visit if they are high risk. Each of these strategies ensures that no women with symptoms are minimized, no warning signs are missed, and no preventive strategies are ignored because her voice was ignored. Just to spotlight our hypertensive collaborative, because it is very effective, it is a registered nurse home visit and also with a telehealth visit within 3 days. So we actually go to mom's home. If she hadn't received her blood pressure cuff, because Medicaid will send them a blood pressure cuff, we will provide them to moms at no cost and teach them how to use the blood pressure cuff at home. We also provide the depression screening for them with the goal of reducing readmission by at least 15% and to ensure compliance with blood pressure checks by at least 85%. Our goal is really 100%, but we know that moms are busy, but we also want to ensure that they are 100 compliant with making sure that they take their blood pressure and report their symptoms. For our Reproductive Health Resource Center, we, as Dr. Corette McCray talked about, we offer family planning. We have PrEP initiation. We had stopped PrEP for a little bit because we didn't have the funding to support the medication, but we have the funding, so we've reinstituted PrEP initiation. And currently, we have about 75 people on PrEP. We continue to do STI management so that we won't have syphilis, congenital syphilis, and perinatal transmission of HIV. We also offer pediatric care at the Maternal and Child Health Center at Laurel from birth to 18 for our adolescents, and we provide immunization care as well as WIC services. Things that we have done internally to improve the patient care experience. We know that people have choice, and we want them to choose the health department as a care provider. Although we don't provide maternity care, we provide preconception care. And things that we have done is to centralize our lab and our check-in process at Cheverly to reduce wait times for people that come to Cheverly. We've added a kiosk so that folks can check in without having to go to the front desk. So our front desk will now need to just enter in financial data. And we've added the ombudsman role for improving client experience. And then this year we added the Black Maternal Health Initiative, thanks to this council's $250,000 award. I want to move on to some shared responsibilities between the health department and our partners. So when we talk about our partners, we have our hospitals, birthing centers outside of our hospitals. We have our federally qualified health centers and other community clinics. We have our Medicaid managed care programs and commercial providers. We also work with the Department of Social Service, Department of Family Service, and Department of, in other departments, as well as Prince George's County School System. And we continue to work with our community and faith-based organizations. Things that the hospitals can do, and I know that they're working on this now, is to implement the AIM bundles around hypertension and hemorrhage to ensure that the 3-day postpartum follow-up is implemented across all hospitals, regardless of where they deliver. Right now, our partnership is with Capital Regional Health. We plan to move that partnership to Southern Maryland MedStar as well. And we will continue to work with our hospitals outside of the county. We know that about 40% of our residents actually deliver at Holy Cross Hospital, so we work in collaboration with Holy Cross as well. One thing that this federal government has done is to weaponize DEI against our community. So we've tried to reframe that in a way that we can continue to receive funding from the federal government by using a different acronym, because DEI was robbed from us, so we used the term ROB. And ROB is representation, opportunity, and belonging. And what that means in practice is our workforce, our leadership, and our advisory bodies must mirror the communities that we serve. So our leadership has diversity benchmarks embedded in our hiring practices. We purposefully recruit from within the community of Prince George's County. We recruit pipelines for bilingual staff and community-based staff, inclusion of community members on our advisory committees and review panels. For opportunity, every single staff member, resident, and partner must have equitable access to the resources that we offer at the health department to ensure that they have an opportunity for advancement and to participate in decision making. We have offered paid internships and fellowship pathways to county residents to work at the health department as a workforce opportunity, to offer transparent professional development, training, and tracks for our own staff within the health department, and equitable funding opportunity for community organizations that work with the health department. How we implement belonging is that every person interacting with the health department should feel seen, respected, and valued. We do this through our community advisory boards, as well as through our ombudsman role. We also offer trauma-informed care and services, as well as communication training to our own staff. We have recognition programs that celebrate the inclusive leadership that we have within our own staff. Our staff are leaders from wherever they are. They don't have to have a title to lead. And then we have data modernization. We are working with OIT to ensure that our data systems transform how we monitor, respond, and lead as a health department through integration regionally and with our state partners. We are working on building real-time maternal health intelligence that support proactive, equitable decision-making. We have interoperability with CRISP, which is the health network across this region where data is exchanged. It dumps into our Epic health chart. We have real-time dashboards that Dr. Sheila Corrett-McCrae works on to ensure that we have real-time data, as real as we can get. We know that the federal government has eliminated the data sources that we used to work with, so we have to produce our own. And then we look at analytics. So we disaggregate geography, race, and ethnicity and insurance status to make real inequities visible and to guide our targeted interventions. And then we look at quality and security. Data governance aligned with state privacy standards, looking at CR 0992025, ensuring that we report appropriately while we protect our privacy of our patients and increasing our transparency. And then the future that we would like to see is predictive analytics for early identification of at-risk population rather than look back. So we will shift from reactive response to prevention, which is what we should do at the health department level. And then when we look ahead for 2026 and beyond, the possibilities are great for the health department to reduce severe maternal morbidity, ensuring that everybody gets that 3-day postpartum contact. Right now we're focusing on high risk. We want to ensure universal doula access for all pregnant women, regardless of their insurance status. We want to make sure that Rob is infused with everything that we do at the health department, ensuring that data modernization is funded so that we can move forward and ensure that we have real-time accountability and public health transparency, and ensure that we align our systems with our contracts. So we are going to be launching performance-based contracting, not just performance measures, but performance-based contracting. And for us, our contracts need to produce outcomes that show that the money that the county has invested is worth the money. And the call to action for this board is to continue to champion accountability, which you do, to support performance reporting and continued transparency in maternal health outcomes across county systems, to help expand coverage for Medicaid postpartum visits, not just with Medicaid patients, but also to expand into the commercial arena, to help us strengthen collaborations across hospitals, because currently you know that our residents don't just deliver in Prince George's County. And then support best practices in obstetric care, including encouraging women to take folic acid, which we know reduces neurotube defects, and low-dose aspirin alone prevents preeclampsia. So in closing, I just want to add that every mother deserves safety, respect, and childbirth worth saving her life. When mothers thrive, families thrive. When families thrive, communities thrive. And that is the legacy we are building here in Prince George's County. Thank you to this council.
Thank you, Madam Vice Chair.
Yes, thank you for your presentation. I did have a few questions. Bless you. One of the questions was around the contact. When you look at the individual contact with the centers, specifically for the Healthy Beginning programs metrics, that one seems to have a steady, low, but steady decrease in individual contacts over the last 3 years. Is there a particular reason why we're seeing that?
Thank you for the question. It was related to funding and staffing. Back in 2023, our state funded shifted. So we were primarily funded under Title V for maternal and child health programming. The state took a portion of our funding and redirected it to have us focus our efforts on pediatric asthma. So we didn't have the availability that we would have had we continued our Healthy Beginnings program the way that it had always been structured. Since then, they have allowed us to take the funding and use it the way that we need to, which is to refocus on maternal health. And now that we have the additional $250,000 from this council, we're able to hire more staff to be able to do the work. Therefore, we expect the contacts to increase as well as face-to-face visits.
Thank you. And just so I can understand, I guess where the staffing exists, because you mentioned Cheverly, for example, is where I guess are the staffing for this program?
The staffing are housed at Cheverly, but they do the work in the community. So if you have to have a home base, Cheverly would be their home base, and that really would be to collect blood pressure cuffs, cribs, or anything that they would need to be out in the community.
And I guess, so if you're a mother and you get connected, where would I guess I'm seeing some home visits, but for all appointments, would you need to go to Cheverly, or how would the mother get the resources or services that they needed? Is there satellite locations?
We take it to them.
Okay.
We take it to them. They don't have to come into Cheverly to access the Healthy Beginnings program. But if they need clinical care, they would get care at Cheverly or the Maternal and Child Health Center at Laurel.
Got it. I guess understanding maybe more about those location choices and I guess why they're the choices based upon is it a demographic? Will the numbers reflect where that Laurel and Cheverly are the best places for the services to be?
So we would have to do an assessment to see whether Cheverly and Laurel would be the best places. Those are our only places where we have buildings. So we are more committed to taking resources to the community. So if we find that we need to set up a satellite somewhere, then we would, because we also have the mobile units that we can use. Mm-hmm. So women are not going to go without. It's not necessary for us to have multiple physical buildings when we have access to our mobile units.
Yeah, I think it's a mixture of both. Yeah, I definitely appreciate the mobile clinics and going to having home visits. But like you mentioned, if you need to go in for testing or you wanted to see a provider, having it in your community, when we talk about our access to preventative care and how certain communities are just kind of basically health deserts. They don't really have access to preventative care. So the only place they can even go is to the emergency room, right? And I know there was a satellite office of the health department in Suitland. I don't know why they decided to move from that building. And so just would love reconsideration about areas like inside of the Beltway. And it kind of goes to a long standing conversation I think we've had as a council, and to the chair's point, when we were advocating for the HIV and AIDS work, all of that work was on the north side of the county, when all of the rising cases were always between his district and mine for number one cases. That's what the data showed, but they had no services in that location. The argument was, well, people could go to that side of the county. Yes, they could, but we just have to make decisions that align with where the need is. And so I would just like us to look at that to make sure that we're where we need those services to be. And then I wanted to understand a little bit more. You gave the example about the home visit and where the nurse came to the home within 3 days. I wanted to know how that program works, where like the nurse would come to someone's home. Like, is that a program that people get into when they're pregnant? It has a cap, like there can only be X amount of people in the program. I'm just trying to understand like what triggers someone being in that program and being able to get the home visit.
So it is, we do it with the hospital. So once we know that there is an admission to the hospital for potential birth, the hospital refers any high-risk mom to us, and they let us know when she delivers so that she can get a visit within 3 days. We do that in partnership with the state, because the state Medicaid managed care programs will send the blood pressure cuff out ahead of time. So I'm not sure how far in advance, but prior to delivery, mom will get this. And they also have a telehealth piece where they talk to mom over the phone to teach her how to use the blood pressure cuff. We take it a step further by actually going out to the house to do an assessment on the mother. So the mother does not have to do anything to get referred to the program.
Is that only if you deliver at certain hospitals? What would trigger that?
Currently, it is only at Capital Region Medical Center,
Got it.
which is why we said we are planning to expand that to MedStar.
Got it. And I know you mentioned the numbers of how many women don't deliver in Prince George's County. So the reality is that there's like a huge percentage that we're going to be missing. I was curious because I didn't have that offered, but I again also had to not deliver in the county, and so I know that might be a hurdle. But just understanding like maybe how we can expand it to at least the two major hospitals that we know, at least if they're Prince George's County residents, being Holy Cross, which you mentioned, and Anne Arundel, which I think probably would be the top two hospitals that a lot of our residents deliver at. And I also had another question. I apologize to my colleagues. I will stop and allow other people to ask questions. It was going back to the program portfolio. I just wanted to understand the reach of the services here. So, for example, you talk about dental services. Because sometimes we see like a list of services, but we're not really sure what does that mean. Does that, if a woman's, for the context of this being maternal care, is pregnant and comes, she gets free dental care? Like, what is it? Just kind of break down what that means and looks like the dental services particularly.
That's pretty much what it means. So
Okay.
we have a real dental office, just
Okay.
like any practice, at the Cheverly location, where we offer maternal and child health dental services. We do preventive services and basic restorative services. And we offer women who are uninsured a sliding fee schedule, and if they pay $2 to $5, that's a lot, because generally it's at no cost. Medical assistance covers our services 100% of the time. And we have started partnership with private payers who, because there are unions that have asked us to have access to our clinic services as well. And we have one full-time dentist and one part-time dentist. And within that clinic, we provide services around maternal and child health as well as to our HIV clients. It's a full-service dental suite.
Got it. And then for the, you mentioned also like the PrEP, and is that to cover the full cost to make it free for PrEP and PEP?
PrEP pretty much is covered now. So when people come in to get referred, in any place where we can link them back to the pharmaceutical company to cover the cost of the medication, we do that so that we can preserve our funds. But most of PrEP is not out of pocket. Most of the costs are covered because we have the additional funds now.
You have the additional funds.
Yeah.
So
Anybody that has private insurance that covers the cost of it, of course, we bill it in private payer.
Right, and if someone didn't have insurance and came in and wanted to, for PrEP and PEP? Or
Yes.
just PrEP? Okay. And then I want to pause to see. Yes, Councilmember Ivy.
Since we don't have a chair here, I don't think,
I'm serving as chair for now.
or you're serving as
Yes.
chair, I guess I missed that vote. My question was about, when you said that 40% of our deliveries are happening at Holy Cross, you didn't say it, but I'm assuming that's because Kaiser works with Holy Cross?
Yes, ma'am.
So they still don't work with the Prince George's Hospital.
Not yet.
Well, it's not your fault, but thank you for the information.
Thank you. Any of my other colleagues have any questions or comments? Seeing none, I'll go back to the question I Again, I apologize for all the questions, but as many know, this is really important
It's
to me.
okay.
And, we have some work coming around this issue, so I wanted to make sure I understood the full scope. Specifically around the services around the doula, because we know that the expansion of that care was passed on the federal level. Is there, so the work you all are doing with hiring a doula, is that around like just educating also, because I think some women don't know that they have access to those services. It's like a campaign, I guess, or education around that, something that you guys are actively working on?
It is. First, we've got to get the doula on board. So we're working on hiring that person. So we've identified somebody from our community who has been a doula for a number of years, who that will be her primary responsibility, to educate the community, to ensure that folks know about their benefit and to know the difference between what a midwife does and what a doula does, because that's still a big misnomer in our community.
Yeah, because you'll see a lot of hospitals try to go the direction of a midwife instead of a doula, and a lot of women and families might not know the difference of like a doula and how they advocate for advocate for the mother, and that's one of the goals in the space and the baby, and it's important that, and you can have both of them. Sometimes they think that they're the same. So I just appreciate the work that you guys are going to do around advocacy. I want to thank you for, we asked for this, I think, report and presentation about a year ago, so I just want to thank you guys for the work that you guys are doing, and hopefully we'll start to see increased numbers. I was curious about the data points being from 2022. When do we expect to see the from 2013 to 2022? Is there another report that will be coming with updated numbers?
Yes. So the data for maternal and child health is definitely delayed a bit. Sometimes this is because of like we said, the mothers that are birthing outside of the county, having to go with vital statistics, some of that. So updated numbers for 2023 are due at some point soon. We don't have an exact date for that, but it would be 2023 numbers that are coming up next, hopefully within the next few months, but the actual date is really not known.
Okay,
And the
thank you.
challenge for us will continue to be the federal missing piece, which allowed us to look at all of the data, and so we don't have that. It will be state-based.
Yeah, we know that's probably going to be a huge issue, but I appreciate that you all are already preparing to collect the data and make sure that, we're still tracking this so we understand what's working and what we need to pivot on. I look forward to working with you guys offline for the advisory board that we've now put together to continue the conversation and really look at what we need to do also in the private sector around education. That legislation also had a campaign component to it. I look forward to working with you all on that as well. There's no other questions from my colleagues. Was there any announcement from staff? Seeing none, is there do we have a quorum yet? Motion to adjourn as Board of Health. Move to adjourn. All those in favor? We are adjourned from Board of Health, and we will start District Council soon. Thank you.